Okay. Good morning, everybody. I am Vinny Della Speranza, and I am a former NSH president. I'm here this morning actually to share with you a society project that we undertook with the CAP. And this is, I think, an important initiative for the following reason. I think the mark of a true profession is one that participates in its own regulation. And I'd like to think that this type of initiative is the kind of thing that might lead NSH into bigger and better things. Can we go to the, oh, I guess I'm controlling the slides. I forgot about that. Okay. All right, so I want to give you a little bit of a disclaimer. I don't know how many can see this. If you have an interest in the slides, you're probably going to need to move forward. I think I've gotten this mostly right. So I'm going to try to give you an accurate snapshot of what we've done, why we did it, who did it, and so on. The project centered around the uniform labeling of blocks and slides. And I'm trying to follow along here on this laptop. So how did this project actually begin? What was the genesis of this project? It turned out, actually, that the Society received an invitation from the CAP in late 2011, and that was to the opportunity to collaborate with them on developing standards for, or at least guidelines for, the labeling of blocks and slides. And I'm sure if we went around the room and we asked everyone, do you know how to label blocks and slides? I'm sure everyone would answer in the affirmative. So when I was first approached by then President Kerry Crabb to chair this project, I was a little bit taken aback because it seemed like a pretty simplistic topic. And I kind of thought to myself, gosh, do we really need to talk about this? But as I later learned, this was actually quite an interesting experience for me because it was actually more involved than I first anticipated. I mean, what could be complicated about labeling blocks and slides? So at least that was my thought process at the time, and some of you may have that same, you may share that same thought process. The project was inspired by a paper authored by Dr. Rosai in 2010. And Dr. Rosai is a world-renowned cancer specialist, cancer pathologist, and he receives consult cases from all over the world. Now, Dr. Rosai's paper was distributed to the individuals who participated in this project, and I'm not at liberty to share it with you, but it was in essence a paper that represented his view that he submitted to the College of American Pathologists on what needed to be done in the discipline in order to enhance patient safety. So what he did in this paper was he recounted to us some of the challenges that he faces when he receives consult cases. And so most of us may be involved with sending our cases out occasionally to other organizations, but we're not the consultant who has to make sense of the material that's been received. And so Dr. Rosai's paper was actually very enlightening, but it was also very prescriptive. When I first saw Dr. Rosai's paper, I became concerned because he was advocating for very specific guidelines that would take away a lot of the flexibility that you and I might have in our respective organizations. He went so far as to create a dictionary, if you will, of abbreviations of stain names so that you would abbreviate trichrome the same way that I might abbreviate trichrome, so that when he has a trichrome slide in front of him, there was no question in his mind that that's what he was looking at. And so he actually took the time to create abbreviations for every immunostain, every tinctorial special stain. And so when you read the paper, he put so much time and effort into this. I was very impressed with it, but also I became a little bit concerned because I know that your environment, your work environment is probably different from mine. And so your needs in the workplace may be different from mine. And so being so specific and so prescriptive, I thought might lead to some concern or problems. Okay, what's on the screen there? There we go. Okay, so I'm going to go to the next slide. I just want to give you a little bit of information about Dr. Rozai because it may be a name that's not known to you. If you go into your pathologist's office, you are likely to find on the bookshelf a book called Ackerman's Surgical Pathology. That's the Bible of surgical pathology, and in fact, Dr. Ackerman is in the picture on the right, and I had the privilege of working with this man for several years, and he was quite an interesting character. There's a story that he tells in the book that I have below, Guiding the Surgeon's Hand. Some histotechs like me like to collect books. If you're a book fiend and you like to collect books and you can get your hand on this one, this is, to me, equivalent to owning the first and second edition of Des Nashian's book, or maybe Priest's book. This is a very cool history, if you will, of how surgical pathology even came around. Most of us were not working or practicing when pathologists were not in the clinical environment. And so what you may not know is that surgeons used to make their own diagnoses. And so surgical pathology had a very interesting beginning. Dr. Ackerman tells a story that he created this textbook actually because he was trying to trip up his secretary, if you can imagine that. If you've ever written a textbook or contributed to one, you can't imagine the amount of work that goes into that. But he talks about being a little bit irked by the fact that no matter what he threw at this secretary, she was always done early, and he'd find her reading detective novels at her desk. So he decides that he was going to write this textbook. Today, this textbook is called Rozai Ackerman's Surgical Pathology. I happened to meet Dr. Rozai in the late 1980s. He was chair at Yale, and he showed me a series of 8x10 black and white glossy photos of Dr. Ackerman in his younger days when Dr. Rozai was a med student. I'm not going to bore you with those details, but these are very interesting people who are world-renowned. And so their names may or may not be familiar to you, but I give you that introduction because I want you to understand why Dr. Rozai's paper submitted to the CAP would have carried so much influence. Okay? So I'll leave it at that. If you can get this book, I highly recommend it. And I'm not parting with mine. Okay, so why did we undertake this project? Well, of course, the ultimate desire was to improve patient safety in surgical pathology. And most of us would not be comfortable going around the room and discussing some of the things that go wrong in our laboratories. That's kind of the unspoken thing. But I think if we're honest with ourselves, we all know and probably remember events that occurred in our labs that certainly had the potential to cause harm, or at a minimum may have caused some embarrassment because the results were maybe confused with another patient, whatever it might have been. We also wanted to consider how labeling practices may contribute to errors in surgical pathology. And I don't think there's any question about that, and I'm going to show you actually examples that I think might resonate with you a bit. We wanted to identify a practical labeling strategy for improving outcomes. And to be quite honest with you, no one has done this previously. So this was actually, we were forging new ground by undertaking the project. The committee did not realize at the outset what we would encounter when we started to look at the scientific literature. But what I want to leave you with is that I believe it's imperative that blocks and slides are labeled in a manner that is informative and clearly understandable to all individuals who may come into contact with that patient material. And sometimes we can't think beyond our own laboratories. We know what we need to do in our workplace, but we're not necessarily anticipating that that case may be leaving our facility and going elsewhere. Now, the process that we undertake each and every day with the specimens we receive is actually probably more complex than we have taken into consideration. Because we do it each and every day and we do it many times a day, we probably haven't stopped to think very much about the overall process. And the process is certainly vulnerable to error. We know we can have errors at accessioning, we can have them at the grossing table. We certainly can have them in histology. So we know, or at least we believe that we know, where a lot of these errors may arise. But the truth is that every now and then I'm surprised that something comes up that, well, let's just say I have some talented individuals in my facility that come up with novel ways to mess things up. So I'll leave it at that. Now, it's been documented in the scientific literature that in most laboratories, each specimen has a minimum of 6 handoffs as you go through the process of specimen receipt all the way through to result reporting. So, and in some organizations, you may actually have more handoffs than that, and you may not have even thought about the number of handoffs. But each time a case is passed along, there's an opportunity for misunderstanding. And so, I do want to make that point because I think it illustrates why discussing labeling is relevant. There are reports of errors in the histology literature, but they're relatively recent. And most of the literature talks about process changes to improve outcomes. So we have a number of presentations on the program this week that discuss how to lean your laboratory, and lean in and of itself is a mechanism for improving patient safety, not only improving efficiency, but also patient safety. Oh, I went too far. Okay. Now, I know that certainly if you pay attention to Histotechnology, I know that we have some very strong advocates for barcodes, and I don't want to give you the impression that I am not an advocate for using barcode technology. But if you are considering adopting barcode technology and not have done so thus far, I would caution you to understand that barcodes do not prevent errors. How do I know? 6 years ago, my laboratory did not have barcodes, but 5 years ago, we did adopt them, and we adopted them wholesale. And we have a tracking system in our laboratory that is not a turnkey off-the-shelf system, but one that was developed in collaboration with Copath. And so we have tracking throughout the laboratory. We can pretty much see where the specimen was in every step of the process, how long it was there, and who did it, who worked on it, and who passed it off. In my laboratory, one of the things that I learned very quickly, I thought barcodes, and in fact, I went to hospital administration and got a rather large sum of money to bring barcodes into the organization in the laboratory setting, and I convinced them that this was going to prevent errors. What it did for us is it shifted the errors to a different place. There's a second problem, and that is that when you give a barcode scanner to a person, they no longer use their eyes. They stop reading. And that's the reality of the situation. You might think that's silly, but let me show you an example. I'm just going to go ahead, and I may have to return. This actually happened in my laboratory. Now, I've tried to be HIPAA compliant by blocking out the first name of the patient. But what we learned very quickly is that if someone in accessioning puts an incorrect label on a container, and you can see both of these patients, their last name is Wilson, but the label on the right, the lower right, that's our label that came from the laboratory information system, and that's the label that gets scanned at the grossing table. And that's the label that generates the printed cassette. And then, of course, those cassettes get handed off to the laboratory where the blocks are cut. And those barcodes on those cassettes get scanned. And the labels are, the slides are printed, and so on. And so we discovered very quickly that even when the information is right there in front of a PA or a path resident, that the information is not being read. They're simply looking for the label they need to scan, and they scan it. And this has happened multiple times. This has not been just a one-time event. Now, I'm going to try to see if I know how to go backward. Is there a way to go backward? Let's try that. Okay. So I'm not here to bash barcodes, but during the open comment period, which I'm going to discuss in a moment, we had a number of people that felt very strongly about barcodes. and who consider barcodes to be an identifier. And I'm going to explain to you why we do not consider that to be the case. So barcode technology, first off, is not available in every laboratory. It's a wonderful tool, so please don't leave the room thinking Vinny's opposed to barcodes. I'm absolutely not. But it is not presently available in every laboratory. Occasionally, the barcode is unreadable for whatever reason, whether it's a printer malfunction, whether it's a scanner malfunction, whether your LIS may be down. There are multiple reasons why that barcode may not be readable. And your barcode is probably not going to be readable in my laboratory. So that's another problem. If we think globally to cases leaving our facility and going elsewhere, that barcode becomes useless in the laboratory that's received your case. Okay, so who undertook this project? As I indicated, then President Kerry Crabb invited me to chair this initiative. And you can see on the slide that we had two co-chairs. We had a physician chair, Dr. Richard Brown, who may be known to some of you here in Texas. He's down in Houston. And I co-chaired and led the NSH initiative for this project. And I do want to thank publicly Janice Alvarez, Jerry Santiago, and Janet Tunnicliffe because they played a very significant role. I underestimated how much work this project would take. And in fact, I'm a little bit shocked that this project took this long to come to a conclusion. We were originally led to believe this would be a 12-month project, and you can see it's 2014 and we're just getting around to filling you in about this. This project is currently, I believe, in the final stages of being completed. We have written a manuscript that's been submitted to the CAP journal, Archives of Pathology and Laboratory Medicine, and we expect that to be in print later this year. Dr. Rosai was on this committee, but he did not participate a great deal. And of course, you may not know, I didn't mention, Dr. Rosai is based out of Milan, Italy. And so his participation would have been via webinar or conference call. We found that he did not participate to the extent that we expected, and he did have some health issues. So most of the physician representation is Dr. Brown, Dr. Eisen, and Dr. Frischberg. Dr. Eisen is located in Connecticut, and Dr. Frischberg, I think, is at UCLA. Okay. So who are the stakeholders? Well, I think probably anyone who's in a clinical laboratory is certainly a stakeholder. And I probably should have said from the outset, if you are not in a clinical histology laboratory, this topic may be of some general interest to you, but is unlikely to affect you in any way, in a formal way. The manuscript that we prepared is being promoted as guidelines for the labeling of blocks and slides. That does not mean that down the road that some of the information contained within that manuscript might not be adopted by the regulatory arm of the CAP. I mean, I think we have to be, we have to recognize that that's certainly a possibility. So the stakeholders certainly are all of us, and surgical pathologists included, and I think industry is stakeholders as well. So we wanted to create what we thought were evidence-based guidelines, and some of you may not be familiar with that term. And that simply means that, that there is data reported in the scientific literature that would support the conclusions that appear in the manuscript that will be published. That was our original intent. But of course, no one had ever done an exhaustive literature search on this topic. And so at the outset, we really did not know if there was a body of literature that discussed the labeling of blocks and slides. Actually, the exhaustive search that we did revealed that there wasn't really any significant published data for us to rely upon. And there was quite a bit of work that we needed to do to evaluate, and I'm going to talk a little bit about the search effort that we undertook. So the document that will be published, the final manuscript, is promoted as recommendations that are based largely on the consensus of the panel. So we did an exhaustive literature search, and if you've not, some of you may be versant in doing literature searches if you have access to a medical library. This was actually a bit more involved, and the CAP has a number of resources available to it, including individuals and experts who guided us through this process, because in order to do a search, you first have to know what to ask. And maybe you've done a Google search and gotten responses that you weren't expecting. So maybe you've had that experience. I know I certainly have. So sometimes the search terms that you use affect the outcome and affect the result. So if you don't select the correct search terms, then you may be unsuccessful in finding valid literature or relevant literature. So we were guided through that process. So a lot of the initial discussion centered around what are we looking for? What are we trying to achieve? And so creating those search terms became the initial focus of the committee. The Ovid Medline in Process, PubMed, and Web of Science databases were searched for the period January 2002 through October of 2013. After 2013, they did go back and do another search to see if there was more recent literature. So we did not write the manuscript without having considered that something new could have appeared in the journals. We also looked at relevant meeting abstracts to see if there were relevant presentations. We looked at pathology journal tables of contents, and we also looked at the reference lists or the bibliographies at the end of articles that appeared as a result of this search to see if there were other relevant publications. So we really put a great deal of work into trying to ferret out any relevant literature in scientific journals. We ended up with a review of 456 abstracts. Now, CAP tells us that's actually a very small study set. So for some of the other initiatives that CAP's undertaken, for example, you know that they recently published guidelines for validations in IHC. The typical hits usually can be in the thousands of articles. And so those efforts can require a great deal of effort. When I saw 456, my reaction was, oh my gosh, that's much bigger than I expected. And I was imagining how much work would be involved in evaluating 456 articles. But I was reassured that this was a small number. Each histotech on the committee was paired with one of the pathologists on the committee, and they were assigned by the CAP staff the responsibility of reviewing a portion of those 456 abstracts. In addition to that, if there were disagreements, so if the histotech said, yes, this should be included, and the pathologist said no, then Dr. Brown and I, as co-chairs, then looked at those abstracts and we made a determination. So we had a process for adjudication to get us through the process. And then once we identified the relevant publications, then of course the CAP staff did data extraction from those papers. Now, of the 456, it may not come as a surprise to you that only 10 actually met our inclusion criteria. And only those 10 underwent the data extraction. All of the 10 reports did not meet the minimum quality standards presented, or they either presented incomplete data or only included information that was based on the opinions of the authors. We were looking for data measurements, someone who could say, in our laboratory, we reduced our error rate from this to that based on labeling changes that we made in our laboratory. That literature simply does not exist. So the inclusion criteria were, well, we wanted to look at surgical pathology. So, and you can see under the exclusion at the bottom, we made a decision from the outset. We would not look at autopsy. We would not look at cytopathology. We wanted to stay focused on surgical pathology cases. We also included original research that described block and slide labeling, so that was an important initial discriminator that we utilized to review those 456 abstracts. They had to be articles printed in the English language, and we wanted to limit ourselves to animal and human studies. Okay? Among the exclusion criteria, we also wanted to ignore or to eliminate articles that focus solely on primary specimen container labeling. We did not feel, and there's a great deal written about that, so we did not feel that that was the focus of this project. The panel met 12 times via teleconference webinars. The chairs met much more regularly than that, although I didn't count those meetings. There were weeks when I'd probably get over 100 emails about this project, and it was a little staggering at times. The panel had 2 face-to-face meetings, one last August in 2013, and then again in March of this year to undertake the writing of the final manuscript. We also conducted a vendor survey. In the beginning of in the outset of the project, we agreed as a group that we did not want to fall into the trap of making recommendations that technologically were not available. So we did poll vendors to ask them a series of questions that would help us to understand what their current capabilities were. Now, we have to understand that as technology advances, it's quite possible that some of the recommendations may be modified. CAP guidelines are reviewed every 4 years. And that's so that they remain current. Am I not keeping up on the slide there? I guess I'm not. Oh, I apologize. See, every time I hit the arrow here, I'm expecting it to change up there, and it's not. And nobody's told me. Everyone's just sitting there very patiently. Okay. All right, so I apologize for that. I've already messed up, and I'm being recorded. Okay. So we also had an open comment period last autumn, in the beginning of the autumn. It was around, I think it began around the time of our conference and then it continued after the conference. And we asked a series of questions, and we showed the individuals who participated in the open comment what our primary statements were at that time. And we asked them to agree or disagree. And then, of course, they had the opportunity to free text in their remarks. And actually, the remarks in many cases were quite enlightening. So we received 539 written comments, and 10 of the 13 recommendations that we had at that time received 80% or greater agreement. So that was good. That meant that we were on the right track. The other 3 that we had received 78 or 79% agreement. So we knew we weren't coming out of left field, and we weren't promoting or suggesting things that were too crazy. 2 of the recommendations ultimately were combined into one. So the final document contains 12 recommendations. 2 of the 12 have received the designation strong recommendation, and that's based on the fact that they are based on existing regulatory requirements. So I'm going to take you through them. If I keep remembering to press the button, so somebody's got to keep me awake here. The first one I'm going to read, and I'm going to read all these to you because I know you can't read them. The very first one says, laboratories must ensure that all blocks and slides are unambiguously labeled using 2 human-readable patient identifiers. In the open comment period, a number of people responded, A, there's no room on the cassettes, B, what about barcodes and identifier? For reasons I think I've already touched on, we feel that the labeling must be human readable because barcodes are not always readable. And a barcode is usually a reiteration of other information that may contain identifiers for that patient. But if you only use your accession number and a barcode, then you have not met the requirement of this first recommendation. The second statement is laboratories should ensure that the accession designation used on the surgical pathology report and all blocks and slides from that accession includes the case type, the year, and a unique accession number. And I think most laboratories already comply with that. So what do we mean by case type? Well, the pathologists on the committee felt that if it's a surgical tissue, then you would use a prefix that in your organization reflects a surgical case. We have different prefixes within my organization, which I have tried to change, but there's been some resistance among the docs. So we have a separate prefix for dermatology, for example. And I kind of like to do away with that. I think some laboratories just use one prefix that might be an S. We use SP for surgical pathology. Don't ask me why, but that's what they've always done. So that's what we mean by a specimen designation. And I think including the year is probably commonplace, and certainly the unique accession number is probably pretty standard in most laboratories. So on the screen, the example I've given you is S14 for the year 2014, and this accession would be 9,999. The next statement, statement 3, reads, if the patient's name is used as one of the patient identifiers, laboratories should ensure that the name format will link the blocks and slides to the correct patient. That sounds like a no-brainer, right? But we run into different issues. So if you were to try to put my name on a cassette, Della Speranza is probably not going to fit. Okay, so we understand this, but conversely, you're not likely to have 2 patients in your laboratory with my last name on that day. So the chance of a mix-up between myself and another patient probably isn't very high. One of the comments that we got during the open comment period was that names are not unique identifiers. That is correct. Okay? There are many names that are commonplace, so we recognize that. Okay? Statement 4 reads, when an accession number has not yet been assigned, like, for example, doing frozen sections after hours, when a pathologist may be working in the laboratory alone. Laboratories must label the blocks and slides with at least 2 patient identifiers, one of which is the patient name. So they can use a medical record number, they can use any number they wish, if they wish to use a number at all. And that would be up to them. But we still want to stress that 2 identifiers are absolutely necessary. So now I'm showing you on the left. If you were to have come to my laboratory 6 years ago, you would be seeing cassettes printed like the image on the left. And I don't know how well you can see those, but this is an old Shandon micro-writer cassette printer. And it certainly served its purpose in the day, but one of the things that you quickly see is the monotonous string of characters that makes it very easy. If you imagine someone at a grossing table handling hundreds of these in a day, and I don't even know if you can read that number. Those of you who are in the front, the surgical case number, this is surgical, says SP10, 12,211. And then specimen I, so that means we had multiple specimens on that patient. And then the last digit is the number of blocks that were derived from specimen I. I looks like a 1, and it's so monotonous that you can imagine it wasn't difficult for residents or PAs to put tissue into the wrong cassette. Now, by the way, we were not using this printer in 2010. We printed these for you so that we could show you that illustration. We still have that printer kicking around, but it's not used in SurgPath. So the image on the right is an example of what's achievable today with current technology that you will find in the exhibit hall. And we may have vendors in this room that would be very happy to show you what they're able to provide to you. These are examples where we have an accession number, we have a 2D barcode, and we have room for a patient name. And I think for laboratories that have not explored that technology, the feedback we got during the open comment period was a lot of skepticism that there simply is not enough room to achieve this. And so I show you the image to convince you that it is very achievable if you have the correct technology available to you. Likewise, we have laboratories that are not automated and are handwriting cassettes, and we understand that. And the recommendations are not intended to exclude those laboratories. If you have a laboratory that's a small volume laboratory, you may not be able to justify the cost of equipment to print your cassettes. But we want to remind everyone that it's certainly reasonable to utilize the sides of the cassettes for some of the information that would be associated with the 2 patient identifier recommendation. Okay, so even when you're handwriting cassettes, you do have the real estate that you need. It may not all be on the face of the cassette, but you'll certainly have it on the cassette. Now, this is an illustration of a range, so I've included the old technology that came from my laboratory in the center, and there's some examples of other things that you might find in the exhibit hall while you're with us during this conference. The lower right-hand picture is an instrument that was just released a few months ago that allows for 3-sided cassette printing. It will print on both sides and the front of the cassette, and it does it rather quickly. I've had it in my laboratory on demo. So the technology clearly is advancing, and I want to congratulate, if we do have vendors in the room, we do appreciate that vendors are doing R&D to improve this technology, because we all are stakeholders, because sooner or later we'll be patients, and we would certainly like people to be issuing our results accurately. Statement 5, which will appear in the final publication, is laboratories should label each specimen container with a unique alphanumeric designation that incorporates the accession number or designation, and each block and slide from that specimen container should be labeled with the same unique alphanumeric designation. So all we're saying is your blocks and your slides have to match the accession number that was on the specimen container that you assigned when it arrived in your laboratory. Oh, okay. Sorry. Thanks, Ione. Ione, keep me on task here, will you? Statement 6, laboratories should label each block obtained from a single specimen sequentially with a unique alphanumeric designation that can be unambiguously linked to a gross description within the pathology report. The order should be accession designation. You and I call that accession number. Specimen identifier. So in my laboratory, our specimens get an accession number. Then each specimen gets a letter. Then there should be a block identifier. So each block derived from that specimen should have a unique identifier as well. So in my laboratory, we might have 2 specimens on a patient, specimen A and specimen B, and we might have 1 cassette on specimen A, but specimen B might have 7 cassettes, and those would be labeled B1, B2, B3, and so on. Okay? Statement 7, when multiple slides are cut from a single block, laboratories should label each slide sequentially in the order of cutting. This slide identifier should come after the specimen accession and block identifier. Now, this is an area that many laboratories may not be currently doing. There was a great deal of discussion among this group about this very issue. We're going to hear a little while this morning about personalized medicine, and we are in an era where we know that we get smaller and smaller biopsies, and very often there's not enough tissue to do all of the things that we'd like to do with those samples. Sometimes tumor may be disappearing in the block. Sometimes as you get deeper into a block, tumor might be appearing that might not have appeared in more superficial cuts. The committee felt very strongly that if you are not currently sequentially numbering your slides, even those that might be collected as unstained slides for the possible use later on, then you need to begin adopting to do that. At least that's our recommendation. We do believe it's very important for the benefit of the patient to know whether the tumor is already gone from the block or whether there's sufficient tumor remaining for some of the studies that are desired to be done today. Statement 8 reads, the laboratory should label the slides with the histochemical, immunohistochemical, or special procedure after the accession, specimen, designation, block, and slide identifiers. So what are we saying? We would like you to have the stain name if you're using a stain, or if a slide is a frozen section slide, then we'd like some indication of that on the label. So I've given you examples of a cytokeratin AE1, AE3 stain, an AFB stain, whatever it might be. Now, what we've not done is we've not adhered to Dr. Rozai's original recommendations. He wanted a very specific library of abbreviations that every laboratory would use. We are leaving that up to you, but what is important is that everyone in your organization knows what your abbreviations are. So that's the key message here. Statement 9 basically states that we made no recommendation regarding the standardization of abbreviations and naming conventions. Okay? You can imagine as new immunomarkers become available, we can find ourselves having to constantly update that library of abbreviations, and we chose to stay away from that. This is an example of slide labeling that you can achieve in your laboratory, and if you are handwriting your slides, you certainly can still get the accession number, the stain name, and the patient name if you choose to use a patient name on your slides. So you can certainly achieve the 2 patient identifiers because we know we have more real estate to work with on the frosted end of a slide. Statement 10 reads, the accession designation should be the most prominent printed element on the block, followed by the patient name and other second identifier. So we're suggesting that some things need to be bolded on your slide or more obvious so that there's less likely for an error to occur. And if you're handwriting, you may have your own creative ways of achieving that. Statement 11, the accession designation should be the most prominent printed element on the slide. So it kind of mirrors 10. We're saying on both the block and the slide, the accession designation is probably the most critical piece of information and should be done in such a way that it brings it to the attention of individuals who need to interpret and read that information. And the last statement, statement 12, is that laboratories should label blocks and slides received in consultation with their own institution's accession designation. But they should not obscure the original label when relabeling slides from another institution. Okay, so anyway, that's the end of this presentation.